Tibial plateau fractures initially presents 1 to 2% of all fractures by model distribution, as many periarticular fractures, 70% in young men age 43 years old, mechanism of injury middle age and elderly with simple fall, commonly split depression type fractures, and less common isolated medial condyle injuries. Higher energy or sports-related injuries are pure split fractures, rim injuries with associated ligamentous injuries. Then another type is high energy motor vehicle injury, often younger bicondylar patterns, high risk of neurovascular injury, compartmental syndrome, and open fractures. Initial presentation is two different types. Lower energy, simple falls, stuck from side, remain length stable. Second class is the higher energy axial load associated with shearing. Compartment syndrome is a risk. Initial management on physical assessment. History is important. Physical examination exclude compartmental syndrome and vascular injury. Ankle brachial plexus index can be done. Valgus instability should be assessed. Splinting with the knee immobilizer, compartment syndrome check, and DVT prophylaxis. Imaging, CT scan routinely obtained, plain films, MRI for occult or suspected fractures, particularly in the elderly. Fracture dislocation patterns and high risk of ligamentous injuries would need MRI. Think about needing for MRI prior to the placing external fixator. Save yourself from some phone calls. Short square patterns. Isolated injuries are mostly lateral tibial plateau injuries. Younger patient, better bone quality, higher energy with associated depression and lateral condyle fracture. Poor quality bone in elderly patient, and some common other patterns. Isolated medial fractures come in two different flavors: low energy and high energy. The low energy are elderly, simple depression, varus loading, fracture line exits medial to the spines. Regarding high energy medial fractures, these are young adult medial shear fractures, vascular injuries. Fracture line exits laterally to the spine, and these are called fracture dislocation variant. Bicondylar fractures, these are high risk of compartmental syndrome, vascular examination, and ankle brachial plexus index is a must. Common open soft tissue injury at risk. Soft tissue is at risk. Exam will progress over hours and often worsens with time. Include varus hyperextension and bicondylar variant. OTA classification: extra-articular, partial articular, and simple articular, complete articular fractures. So type A is extra-articular, type B is partial articular, type C is complete articular. Important variants: open fractures, antibiotic, tetanus prophylaxis, and vascular examination is a must. Presents challenges for coverage. There may be shaft extension. Early coverage within 72 hours decrease rate of infections. Fracture dislocation patterns: a medial displacement and shortening. Associated with vascular injury, subluxation or dislocation through the fracture site causes traction injury to the vessels. Don't always fit into short square and needs a Hall and Moore classification is more descriptive. A 3-column concept has been described. Evolution of the Scharzer classification better incorporates the fracture involving posterior tibial plateau, helps with determining appropriate fixation strategy. General fixation principles of plateau treatment: fracture location and classification generally dictate approach. It can be anterolateral, posteromedial, or direct medial approach. Visualization of the fracture is key for articular reduction. Direct visualization, that is anterolateral or submeniscal approach. Fluoroscopic, that is minimally invasive reduction techniques, or arthroscopic in conjunction with fluoroscopy. Use of temporary external fixation may be considered. Fractures which are length stable can be safely delayed with bracing alone. Non-operative management. Undisplaced or minimum displaced fractures, small depression, lateral tibial plateau fractures are without deformity or instability, significant medial comorbidities that preclude surgical fixation, elderly patient with low functional demands in whom subtle deformities are tolerated. Contraindications to conservative management is knee instability, greater displacement where deformity is easily repairable, and displacement of the medial side or medial side injuries. Non-operative management is indicated for valgus instability 5 to 10 degrees. Articular step-off threshold is controversial. Some would dictate 3 to 5 mm of depression. In generally small isolated lateral injuries without valgus instability should be managed conservatively. Early range of motion, limited weight bearing 8 to 12 weeks, and bracing. Angular malalignment are poorly tolerated. Now, considering lateral tibial plateau fractures, anterolateral approach, submeniscal arthrotomy, distractor if needed, book open the split portion or reduce the depressed articular segment and provisionally stabilize with K-wires, fill the void with as necessary, reduce the split portion, apply rafting screw and a lateral plate. Post-operatively, early range of motion, trust your fixation and protected weight bearing for 8 to 12 weeks time. Bracing is controversial. DVT prophylaxis is indicated in those 8 to 12 weeks. Isolated medial injuries, posterior medial approach, much less commonly. Posterior medial approach, the isolated medial injuries are less common. Isolated posterior medial approach, prone versus supine. Supine in simple allow for interlateral approach. Also add significant rotation in varus, often through the fracture in bicondylar injuries. A posterior is inconvenient but fewer deforming forces and simplified fixation. Direct approach to the apex, indirect reduction at joint line and fluoroscopic reduction is the key. In isolated medial injuries, you have to prevent late varus deformity. I love an Holler approach, that is interval between the hamstring and the medial head of gastrocnemius. More complex injuries like bicondylar fractures, neurovascular injury is crucial. Apply external fixator, can change the vascular exam. Restoring length can increase compartment pressure as well. Extensile posterior medial approach, standard Loban-Holler approach with an extended proximal limb. Isolate the medial head of gastrocnemius at its femoral insertion. Release the medial head. Provide access to the portion of posterior lateral plateau as well. Medial bicondylar fractures. Decision making. Regarding the medial side, if there is a posterior shear fracture, you should add posterior buttress plate. There is unstable medial column, direct medial plate is advised. Axial CT is helpful. Fixing from medial or lateral alone may entirely miss posterior medial fragment. Think of 3 columns instead of the 2 column. Buttress posterior fractures at the apex. External fixator and fasciotomies are sometimes required. A possibility is medial side is limited proximal exposure with a bridging plate distally. The bridging plate technique. If the fracture a plateau that extends to the shaft, or it is a shaft that happens to extend into the plateau. Question mark. Simple fracture lines calls for anatomical reduction. Percutaneous bridge plating used for more comminuted diaphyseal fracture with proximal extension. Associated shaft and plateau fracture needs combination of two techniques. Present in extremis, bilateral open tibia, associated bicondyle plateau on the left side, emergent external fixator and VAC application, return for fixation later on with flap HD3. Regarding the rehab can be very dependent on the fracture type. Goal of surgery is allow for a complete range of motion immediately post-operatively. Unlock hinge knee brace commonly used. Consider appropriate DVT prophylaxis. Touchdown weight bearing for 8 weeks. Advance after 8 weeks depends on severity. Quadriceps set and isometric exercises are important.